Good afternoon. I'd like to thank the organizers for inviting me here today to speak about work we've been doing on modulation of innate immunity and how that's opened the windows to treatment of inflammation-driven and infection-driven disease in ways that have not perhaps been previously considered. So Logenix is a public company, and so we must start, of course, with the obligatory forward-looking statement. But beyond that, let's consider what we mean by innate immunity. Your innate immune system is the body's partner to the adaptive immune system. And the adaptive immune system is what everyone thinks about when they think about antibodies and T cells. The adaptive immune system excels in learning from infections that occur in your body and generating a memory response to those infections, amounting an exquisitely sensitive and specific response should those infections occur again. The innate immune system is entirely complementary to that. It doesn't try to learn from infections that occur from within the body, but rather has a pre-programmed response to known markers of infections and tissue damage. Because it's a pre-programmed response, it's a very rapid and yet non-specific response. More importantly, however, innate immunity isn't limited to what happens in your circulating immune system, but also involves a number of tissue-resident cells, and that are especially active at all the barriers between the host and the outside world. So you can think of the skin or the lungs, the lower GI tract, or the oral mucosa, for example, all would have cells that are highly active in innate immunity. Finally, the other component of innate immunity that everybody thinks about is inflammation. And while everyone knows that a lot of inflammation is bad, often we forget that a little bit of inflammation is good. However, perhaps more importantly, we can actually separate the effective inflammation from the tissue healing and bacterial clearance mechanisms of the innate immune system. And this separation of effects is one of the things that we're going to leverage with our innate immune response today. So when we talk about leveraging the innate immune system, we're actually referring to our technology platform that deals with innate defense regulators. Innate defense regulators are fairly unique in the world of innate immune modulation because instead of trying to target one of the many inputs or outputs to the innate immune system, instead we try to address a key convergence point in the intracellular signaling network of the innate immune system, much like Steve was speaking to nodal points earlier today. The innate defense regulators, the lead compound of which is SGX-94, which has been in clinical trials, and we'll review some of that data today as well, actually targets one of these intracellular convergence points, binding to a protein known as P62. And because it is at a key decision gate in the signaling mechanisms, it's able to influence the downstream pathways that come subsequent to any challenge to the innate immune system. And the influence it has is that it increases the selective effector cell recruitment. Think generation of macrophages and monocytes at the site of infection, for example, while at the same time controlling inflammation, biasing the response to be a little bit more anti-inflammatory and a little bit less inflammatory. As I noted, SGX-94 and the other innate defense regulators bind directly to this protein, a scaffold protein known as P62. And by binding at that scaffold protein can change the protein-protein complexes that are involved at this nodal transmission point. Now, while the details are probably too complex to get into in this short presentation, the majority of them have been published. And what's important to understand is that the effect of SGX-94 here is very selective, increasing signaling, for instance, through the CEBP beta transcription factor, but not altering signaling through the NF-kappa B transcription factor, which is known to be quite inflammatory. Interestingly, a lot of this work was informed by the type of proteomics analysis known as SILAC, which was described in one of the plenary sessions earlier today. The fact that the innate defense regulators are targeting this internodal signaling point in the innate immune signaling pathways means that they actually operate downstream of a lot of different stimuli to the innate immune system, and this gives them very broad spectrum activity. So thinking about it from the infection component, the IDRs have been shown to improve survival and enhance bacterial clearance downstream of a variety of different infectious pathogens, whether they be gram-negative or gram-positive, extracellular or intracellular, and antibiotic sensitive or antibiotic resistant. And this is because the role of the IDRs is to enhance the host response and not to target the bacteria directly. Moreover, it doesn't really matter where the infection or tissue damage occurs because the innate defense system is effective at a lot of different anatomic locations, as we discussed earlier. And moreover, because of the mechanism of action, any action of the drug SGX-942 is complementary to those of antibiotics. But we don't just have to think about infection. We can also think about animals that are otherwise immune compromised, since most immune compromise occurs due in the circulating immune system. And moreover, we can also think about tissue damage and the ability to aid in the resolution of this tissue damage and any acute inflammation that occurs subsequent to any tissue or inflammatory damage. So in all of these contexts, innate immune treatment may be very relevant, and we'll show some examples of that here as we go forward. If we start from an anti-infective perspective, the innate defense regulators are also interesting because they show therapeutic as well as prophylactic activity. Previous attempts to modulate the innate immune system have really targeted specific inputs to the innate immune receptors, and this has meant that while they show very good prophylactic activity, they aren't able to show very good therapeutic activity because they also engender a strong inflammatory response. In contrast, because we deal with a nodal position in the intracellular signaling pathways, the innate defense regulators are able to act therapeutically, and we show two examples here on the left-hand side with a gram-positive antibiotic-resistant bacteremia, and on the right-hand side with a gram-negative leukopenic septicemia, again reinforcing the very broad-spectrum activity of innate defense regulation in the context of infection. But how does SGX-942 achieve this anti-infective effect if it's not directly killing the bacteria? Well, of course, the answer is by working through the innate immune system, and more specifically here we see that macrophages are a particular target of action of the innate defense regulators. So this is an example of an peritoneal infection. In fact, it's an infection with a MRSA variant of Staph aureus, and we see that in the infection cavity when we treat with SGX-942 we get increased recruitment of macrophages to that site of infection, irrespective of how we administer the SGX-942. So the SGX-942 can be administered directly into the infection site itself, or it can be administered intravenously. Since it works in either way, the SGX-942 itself would not be considered chemotactic, and that raises the question, then how are the macrophages recruited to the site of infection? If you look again in that peritoneal infection model at what chemokines and cytokines are being expressed prior to bringing in the macrophages, you find indeed that there's an increased expression of chemokines that are responsible for recruitment of macrophages in that same compartment. Again, irrespective of how the SGX-942 administered. In this case, it's administered intravenously. And in fact, if you look a little bit later at 24 hours post-infection, you also see that anti-inflammatory effect we were speaking of earlier. On the left-hand side of this graph, you can see that the TNF-alpha levels in the peritoneal infection have fallen substantially in the SGX-942 treated group. In fact, though, this effect of modulating inflammation is not dependent on having an overt infection. On the right-hand side, you see another example. In this case, what we've done is we've challenged the mice of lungs using endotoxin and looked at the levels of cytokine expression in their lung fluid. Here we see that inflammation is actually decreased by increasing the anti-inflammatory expression of IL-1RA, again reinforcing that the effect of the innate defense regulators on inflammation is fairly broad spectrum across a number of different markers. I also mentioned earlier that the innate immune system also has tissue-mediated effects, and here we've done a little bit of an adoptive transfer experiment to show that. So we've taken spleen cells from mice and excised them and treated them with endotoxin, and then some of the spleen cells are subjected to IDR treatment at the same time and some are not. Now the IDRs break down very rapidly, so by 24 hours after this there's no innate defense regulators left in the mixture. Nonetheless, we can take that conditioned media and put it on macrophage cells, and that's what raw cells are, and ask how the raw cells are responding to the signaling from the spleen cells. Here you can see two examples where we see that both the anti-inflammatory activity of the IDRs, resulting in decreased IL-6 and TNF-alpha in the macrophages as a result of this signaling from the spleen cells. Moreover, you can also see that if the analog of SGX-94 does not bind to P62, it does not have a very strong anti-inflammatory effect, whereas if it's a slightly better binder, it can have a slightly stronger anti-inflammatory effect. And this suggests that the responsiveness we are seeing correlates well with the P62 binding affinity I'd spoken of earlier. In fact, we can take this tissue healing examination one step further and ask if there's any tissue healing activity. The first place we looked at this was in actually a tissue/infection model where we had some epithelial damage to the skin of a mouse due to reapplication of tape on their skin, which was then exposed to MRSA. And you can see at the 48-hour time point that both the antibiotic and SGX-94 were able to reduce the ulceration due to infection with a single treatment. On the other hand, if you look later at 96 hours when the tissue is starting to heal, you can see that SGX-94 is having a markedly improved effect on reducing the swelling and accelerating the tissue healing in this tissue. In fact, we can take the tissue healing aspect one step further and think about it in the context of oromucositis, which Steve was referring to in the previous talk. As you know, the chemotherapy and radiation does damage to the cells, and the damaged cells then release damage-associated molecular patterns, which engenders an innate immune response. Now, sometimes that innate immune response can be overenthusiastic, resulting in enhanced damage, and this is believed to be some of the pivotal underlying etiology of oromucositis, and in fact, a mucositis of the lower GI tract as well. Here we're showing some preclinical data on the left-hand side, oromucositis induced by radiation, fractionated radiation, where we can see a 50% reduction in the duration of oromucositis. And on the right-hand side, chemotherapy-induced mucositis, both in the oral cavity as well as in the lower GI tract, both cases of which we see an approximately 50% reduction in the duration of the mucositis due to treatment with SGX-94. We can also think about this in other frameworks of acute GI injury and inflammation. Here we have an intestinal bowel disease model where we're giving oral dextran sodium sulfate, which damages the GI lining. And we can see that treatment with SGX-94, either beginning before, during, or after that damage has occurred due to the DSS application, still results in a statistically significant improvement in the colitis measured in the GI tract. In fact, the innate defense regulators are also unique in that they have a very enduring pharmacodynamic effect. What I may not have mentioned explicitly up to this point is that SGX-94 is a peptide product composed of all L-amino acids, and it has the very rapid PK that you would predict for a product of that nature. Nonetheless, we have seen very extended pharmacodynamic effects, and this again is due to the fact that the peptide is eliciting responses in the innate immune system, and the responding cells then have an enduring effect. So, for instance, we've seen that we can treat up to 5 days prior to infection and still have a prophylactic effect on the infection. We can also look at more therapeutic treatment and find that treatments within, say, 24 to 48 hours don't really have any added benefits, whereas treatments beyond 48 hours, closer to 72 hours, do have the potential for added benefit. While this is difficult to show in an acute lethal infection model on the left-hand side, it is more easily examined in something like an oromucositis shown in the right-hand graph. In both cases, you can see that certainly dosing every 24 hours didn't result in any added benefit, confirming the extended pharmacodynamic effect of the compound. So the question then becomes, how does all of this translate to the clinic? Clearly, from the preclinical perspective, we actually thought translation to the clinic should go quite well, and this was for two reasons. One, that the innate immune system itself is actually present in all orders of mammals and is highly conserved. But secondly, that the target protein itself, P62, is also very highly conserved, with 91% sequence identity between mouse and human. Of course, nothing is so good as proof and data, so we've now completed 2 clinical studies, a phase 1 study in 84 healthy human volunteers and a phase 2 study in head and neck cancer patients, both of which I'll show in the subsequent slides. But just to preface my findings, what we did find here was that there was complete concordance between non-clinical and clinical results in both of these clinical settings. So to start with that phase 1 study in healthy volunteers, the compound was SGX-942 in this case, was very well tolerated, and we collected whole blood samples from the healthy volunteers that were given either SGX-942 at various doses or placebo, and then stimulated them with endotoxin to see what degree of inflammatory response we would get in the presence and absence of treatment. And here we saw, very similar to what we saw in our non-clinical studies, there was a statistically significant anti-inflammatory response, especially in subjects receiving between 1.15 and 2 mg per kg of the SGX-942 product. So we see here that this response was also pretty broad spectrum. It wasn't localized on any one cytokine or chemokine, but rather we could see an increased IL-1RA signal coupled with a decreased IL-1 beta signal, an increased TNFR2 signal coupled to a decreased TNF-alpha signal, and moreover that this impact could be sustained through 96 hours post-administration. It was also interesting to see that the non-linear dose response, which we'd previously observed in the non-human primates, was also observed here. This type of nonlinear response is not entirely unexpected because as you think about rebalancing pathways, it's entirely expected that at some point that rebalancing between the two sides would result in different outcomes at higher dose levels. However, we were only able to see this in the primates and humans because it's harder to dose quite so high a level in the small furry rodents. On this data, we moved into our phase 2 studies in oral mucositis. Now, oral mucositis, as I described earlier, is both an inflammatory disease as well as obviously having a tissue healing component in it. And as such, we really expected to have better efficacy at that lower dose, the 1.5 mg per kg dose, although we did test 2 dose levels, 1.5 and 6 mg per kg. Here we enrolled 111 head and neck cancer patients that were expected to receive at least 55 gray of radiation and were receiving also either weekly or every 3rd week cisplatin chemotherapy. And we see that in the general population we reduced the median duration of oral mucositis, severe oral mucositis, from 18 days to 9 days. Now this is very important because severe oral mucositis is patients who can't eat and or drink due to the severe pain in their mouth. It's extremely debilitating and can result in dehydration and malnutrition as well as hospital admissions, all of which lead to poorer outcomes. In fact, we also identified a higher risk subpopulation that actually had a median duration of 30 days of severe oral mucositis, and this was further decreased down to 10 days, a 67% reduction. However, in addition, this patient population receiving chemoradiation therapy is also very susceptible to infection, and of course infections were monitored as adverse events in this phase 2 study. All concurrent treatments were allowed, antibiotics, what have you, either prophylactically or therapeutically, and against this very heterogeneous background, we were nonetheless able to identify that the SGX-942 treated groups had a significantly reduced incidence of infection, both all infections as well as non-fungal or bacterial infections, as identified as adverse events. In fact, there were a number of ancillary benefits that we identified with treatment of SGX-942 in the oral mucositis setting in these head and neck cancer patients. In particular, we looked at the rate of tumor resolution, clearly an important safety endpoint in this patient population, as Steve referred to earlier. And in fact, we saw that at the 1-month time point, there was an enhanced rate of tumor resolution in the SGX-942 treated group. This tumor resolution was sustained through the 12-month follow-up period that we continued to monitor these patients, suggesting that SGX-942 potentially provides an accelerated rate of tumor resolution in these patients. This would actually be consistent with our preclinical data, which we've not shown today, but which we have published, which indicates that SGX-942 may in fact have a potential for a direct anti-tumor effect as well. Of course, as we continued to monitor the patient over 12 months, we also monitored survival. And here we see again that SGX-942 appears to provide a survival advantage in this 12-month follow-up period. If we think then about the IDR program from the big picture, obviously we've demonstrated that these compounds have very rapid pharmacokinetics given their molecular structure, but that they also have an enduring pharmacodynamic approach. The compound was very well tolerated both in non-clinical toxicology studies but also in phase 1 and phase 2 clinical studies. And this suggests that the innate immune response is something that can be safely manipulated in a human population. Moreover, all of the data that we saw in our small furry creatures, all of the different mechanisms and modes of action of SGX-942 appeared to translate into the clinical setting, and this suggests that the innate defense regulators could provide benefit across a range of potential indications. We do, of course, have a portfolio of IDR analogs, and we have initiated explorations of other potential indications while we continue to conduct a phase 3 clinical study in oral mucositis. In fact, if we take a step back and think of targeting the innate immune system in more detail, we can think of a wide variety of potential indications which may benefit from IDR treatment. This ranges from oral mucositis and head and neck cancer to mucositis and other cancer populations to other secondary effects of chemoradiation therapy. There's also the anti-infective mode of action, which clearly has a broad spectrum of activity that's applicable in antibiotic resistant and emerging infectious disease. And there's also the consideration of acute inflammatory syndromes associated with triggering an innate immune response to an exogenous stimulus, such as intestinal bowel disease. Clearly, we've also discussed today the potential for having a direct anti-tumor effect. Although this is certainly something that's of interest, it's not something that Sologenics is clinically focusing on at this time. Finally, I'd just like to take the opportunity to thank our collaborators over the years, obviously Dr. Stephen Stonis from the Dana-Farber Harvard Cancer Center, but also our collaborators at the University of British Columbia, and of course our funding agencies. Thank you again for giving me the opportunity to present here today.